Good morning, everybody. Can you hear me? We're going to get started with the day's activities. Thank you for coming to our first lecture this morning. I'm Kirsten Lomala, your president-elect, and it is my distinct honor to introduce the speaker. Nina, and I'm going to probably say your name wrong, I apologize, Paranishvili. Perfect. She obtained her physician assistant degree from the University of Toronto in 2018 and has been working in addiction medicine since then. While working on a research study, Challenges in the Diagnostic of Polycystic Ovarian Syndrome in Adolescents, Nina developed a passion and interest for fertility medicine. In March of 2021, she started working part-time in fertility medicine, and she works currently with Dr. Tanya Williams Fertility Center, where treatment is provided for all causes of female infertility. Nina?
Well, thank you very much. Oh, that's too loud. Thank you very much for introduction. And thank you very much, everybody, for coming in today. It's a rainy Saturday morning, so it feels like cozying up in a blanket, but thank you for being and attending my talk. And as it was said, by no means I am an expert in this field because I started fairly recently. It's been about a year and a half. But I did develop passion fairly fast to this field because once I go through it, you'll understand people go through struggle, and it's a very rewarding field as well. And so the main, give me one second, the main objectives, I guess, for the lecture is for me to increase the awareness about fertility because it is underdiagnosed. The prevalence is quite high. Up to 15% of people suffer from infertility. Couples, I should say, suffer from infertility. A lot of the times, doctors do not start talk until it is very late, and it is a very timely matter. And as we go, you'll kind of learn why. Now, I am hoping to go through, work my way through the case as well and touch on PCOS, and I won't be able to cover all the causes of female and male infertility, but I do want to touch bases on some of the common ones for you guys to have a structure or identify or maybe be able to refer patients sooner. Some of the basic fertility workup that we do in our clinic, and clinic, it varies probably from clinic to clinic, but main principles, if you will. And I'm hoping to answer all of your questions at the end. And if not, if I am not able to, I have a very supportive Dr. Williams who I can consult and answer them as well. Now, I wanted to share some of the slides from this is American Association of Reproductive Medicine, a wonderful organization. And what this slide really represents is that a lot of the times doctors refer a female, right? It's assumed it's a female issue, but statistically, 30% of the time it's a female factor, 30% it's a male factor, but 40% adjustments requires on both ends. And some of the percentage we can't even identify the cause. Now, as we all know, infertility is basically inability to conceive after 1 year of unprotected regular intercourse. Now, it varies from age, right? So if female specifically is less than 35 years old, then we do advise to try for a year. Anywhere from 35 to 40 years old, we advise to try 6 months. If the female is 40 or above, or there is any risk factors, we advise to refer immediately. And so the risk factors are, for example, obesity, diabetes, pelvic surgeries, abdominal surgeries, right? Now, this is a largely schematic representation. As my doctor says, it takes two to get a baby, right? So we need a functional sperm. And when we do assess sperm, there is multiple sperm assessment like DNA fragmentation test or sperm chromatin assay and some more advanced sperm assessment tests. But the most commonly done, and most of you may have heard, semen analysis, right? Where we assess what's the percentage of motility, mobile sperm, the amount, the concentration, basically do we have enough sperm in the semen, and morphology or well-shaped sperm, right? And so for female, of course, we need to know that there is a, functional female genitalia, so functional vagina, cervix, uterine cavity, right? Because if there is fibroids, polyps, that prevent implantation or even prevent sperm from moving to the fallopian tubes, for example. And of course, functional fallopian tubes, we need ovaries, and ovaries must ovulate, all right? And this all with endocrine system kind of oversees all of this, right? So we have hypothalamus that produces gonadotropin releasing hormone, which acts on anterior pituitary, and then that in turn kind of produces FSH-LH, which acts on in male cases and on testes and produce testosterone, and in female cases ovaries to produce estradiol progesterone, right? And so this graph I also wanted to share. So what it represents is that there is a marker called anti-Mullerian hormone, or AMH, and we do it routinely for every female. And what it shows us ovarian reserve or reproductive potential of the woman. And what this graph represents is that, as you can appreciate, after age 35, so this is a number of functional follicles. And you can appreciate that after age of 35, the number significantly drops. And we do need to identify early, right? And what is how do you start conversation? And this is also from American Society of Reproductive Medicine. So what they suggested for primary care doctors or physician assistants or nurses. So this is one way to start conversation, right? To ask the question, what are your thoughts about your family in the future, right? And some people will kind of shut it down, and that's okay. It's their choice, right? But some people will, well, I'm glad you asked, right? Because they don't know, are there fertility doctors? And so it is important, because after age 35, you see significant drop of number, and not only quantity, but the quality of follicles reduces as well, right? So identify, start the conversation, and refer them early, because it's very hard to fix things at 40, because statistically, really, there is 1 to 2% of chance of pregnancy after 30, and that's with everything functional per cycle, of course. So yeah. Now, I'm not going to dive into male infertility because, well, a couple of reasons. This is not something that we practice and take care of. I mean, the basic stuff like maybe decreased motility or something we do take care, but if there is something more, we refer to urologists. But I did wanted to give you some kind of idea. I classified it this way, and this could be classified any other way, just to kind of give you some idea. So it could be genetic causes, right, for male infertility, like XXY or Klinefelter syndrome, congenital abstinence of vas deferens, and this is some cystic fibrosis patients could have this. So sometimes we do screen for cystic fibrosis if we pick up something on ultrasound unusual. Some sperm delivery disorders, and this could be poor coital intercourse. It could be issues with obtaining and maintaining erection, or ejaculatory dysfunction. Now, endocrine disorders, chronic illnesses affected, right? Like ulcerative colitis, Crohn's disease, any inflammatory bowel disease will affect it, because there is an inflammation, and it does cause synechia and adhesions and so forth. Now, infections, injuries, anti-sperm antibody is an interesting one, because sometimes we have patients who had vasectomy and then they had reverse vasectomy. But after a certain time that you have vasectomy, anti-sperm antibodies start to develop, and really their own body attacks the sperm. And so varicocele, cryptorchidism, and some causes are idiopathic, right? So those are some of the male causes of infertility. So for female, it's this is where we specialize, and this is again the way I classified it. It could be classified any other way, but in my head this made sense. So I classified them in ovulatory dysfunction, right? So this is going to be your PCOS. This is going to be ovarian insufficiency, or known previously as premature ovarian failure, right? And just to kind of briefly stop here. The causes of premature ovarian failure could be simply genetic. It could be autoimmune. It could be 45XO, right? Turner syndrome, Fragile X syndrome, or any kind of pelvic chemo radiation therapy, or simply idiopathic. And then reduced ovarian reserve. This is the AMH that we spoke about. After age 35, it does significantly drop. And then prolactin disorders, thyroid disorder really matters, because it's very important to have a tight thyroid control when you're trying to get pregnant and during pregnancy as well. Then I classified them as tubal factors, right? Basically by organs. So this could be endometriosis. Is there some kind of obstruction, pelvic surgeries in the past, STIs, pelvic inflammatory disease, right? And then uterine factors, endometriosis here as well, because if there is a large endometrioma that prevents implantation, that could play a role as well. Fibroids, polyps, quite benign, as well as fibroids, but depends on location, depends on the size, they do matter. Unexplained 50%, and I put it separately because I do like my patients to let them know very initially that we might do all these tests and investigations and we don't find the cause. There might be no female or male factor, and it's very important to be upfront, right? Because they would want answers at the end of your investigations. Now, autoimmune disorders, and those more commonly like SLE or antithyroid antibodies, those disorders do cause recurrent pregnancy losses more so secondary infertility, if you will. And BMI really, really matters. Over 30, usually ladies with BMI over 30 do have irregular cycles. And not only that, there is a higher complications during pregnancy, during delivery, and complications for baby as well. So we do suggest lifestyle adjustment here quite a bit, and I'll kind of talk to you a little bit later about lifestyles. So I printed out this, and I don't know if you can actually see this, but these are some of the investigations we do in our clinic and some of the routine ones. It, of course, changes based on specific case or specific clinical presentation and scenario. But basically, what we usually do, we ask female to call us on day 1 of their cycle. Meantime, male is investigated for DNA fragmentation, semen analysis. We do it twice just for accuracy of the test. And they're investigated for blood work as well. But meantime, we ask female to call us on day 1 of their cycle. On day 1, we typically, tell them to come in on day 3, and day 3 is an important one. So we do bloods like hormone estradiol, progesterone, FSH, LH, all the hormones that are required for pregnancy to happen, right? And so, and we do ultrasound, and then we bring them on day 8, 10, 12, 14, even 16. So we bring them every other day from day 8 for blood work and ultrasound, and we monitor basically, are the hormones appropriately increasing or decreasing according to the time of their cycle, and follicular development, right? Do we have enough follicles? Are they growing in size? Are they ovulating? When are you ovulating? When they are ovulating? Now those sonohistogram, like the middle picture. And the reason this is routinely done in our clinic for every female, just basically we are trying to see if all the ingredients that are needed for pregnancy are there and are working, right? And we do need to do this. Some people will say, well, can I do it later? But the thing is, if we put this one aside, we are putting all this time and energy into treatment, and we don't even know if the cavity is functional, right? So it's such a waste of effort and time and money sometimes as well. And so a sonohistogram, so uterus is like a clenched fist, right? Like literally it's a collapsed muscle, the size, and that's how it usually is. So what we do is we infuse tiny amount of saline, and so we dilate it like a water balloon. And so we check if there's anything in the cavity, right? Because this is the only way we can really appreciate 3D. Like even if typical like transvaginal ultrasound says there is a fibroid or polyp, it's not really accurate until you really stretch the uterus and really appreciate where is it, what is the 3D dimensions, right? And then more importantly, fallopian tubes, are they open? Because again, that's how sperm travels to fertilize the egg, right? And then the last picture is biopsy. This is one of the procedures that ladies really don't like. It's quite uncomfortable. But this is a thin catheter, which I usually, it goes through vagina, through cervix, and we go into the uterine cavity. This is mostly done for people with PCOS or any anovulatory dysfunction, right? People who do not ovulate, because anytime somebody tells us, my period is every 45 days or every, I don't know, some women have once or twice a year, right? And so what it means to us is the endometrium or inner uterine lining is exposed to unopposed estrogen, right? And so that causes proliferation and growth of inflammatory cells. And so we go through cervix into the uterine cavity, and it works like a little vacuum. And so it kind of sucks little pieces out, and we check if there's any inflammatory or abnormal cells. And this rules out really chronic endometritis, right, which could also prevent implantation and fertility in general. So Sheila is a 30-year-old and Ron, her partner, 31-year-old, are a lovely couple who were referred to you by a primary care PA for primary infertility for 1.5 years. Now, briefly, I want to stop before I ask you a question. Primary infertility. So this is infertility, as it said, like name says itself. So person was unable, or couple they were never able to conceive prior. There is a secondary infertility that they either conceived, there was miscarriage, or they have a kid and then they can't get pregnant anymore. And it's not uncommon. Sometimes, especially males, I have to say, will come and say, well, I already have a kid, but it doesn't guarantee that you can still have a kid, right? Because with time, things change. Now, any questions that you would like to ask this couple? Just general questions. It's a small audience, so maybe shout out anything you're interested to know. Sorry? STIs, wonderful, relevant. Are they having sex? That's, you would think it's a common sense, but you'd be surprised. You'd be surprised. Cycle? Yes, yeah, very relevant, right? And so, yeah, all of it is here. So what we usually ask prior investigation, this is for male. Again, we only ask as much as we can manage, right? And I'm sure urologists have completely different approach, but we ask prior investigations. Was there any semen analysis done, right? For have they ever fathered pregnancy outside of this relationship, right? Any issues with either maintaining, obtaining ejaculation, erection, ejaculatory dysfunction, libido, has it been somewhat steady or has it been dropping, right? Age of puberty matters, past medical history matters, especially moms, because it could cause orchitis, right? Or cryptorchidism could also cause infertility. Social history is very relevant. So recreational drugs, cannabis, nicotine, they do affect sperm quality. And some people will say, well, I only smoke once a week just to fall asleep. And there is no safe amount. So if we will say to really optimize your reproductive potential, abstain. Typical recommendation for alcohol while people are trying to conceive is no more than 2 days a week, no more than 2 glasses per that occasion. So the less, the better. And no nicotine, no cannabis, no recreational drugs. Now, exposure to heat, very important. Tight pants, tight underwear, excessive saunas, bicycle rides, because spermatogenesis is a very temperature-sensitive process, right? So there is a cremaster muscle that, if it's too cold, it will contract and pull testicles towards the body to keep the optimal temperature, and then the other way, right? It relaxes and pushes them away when needed. And so we go in details through this with the male partner: allergies, medications, family history, occupation, ethnicity, diet, sleep. Sleep is something that people really underestimate. So ideally, we want couple, while they are trying to conceive, and probably for everybody, 7 to 8 hours of sleep per night, right? And that's an optimal time, because a lot of times, if not all the time, if you sleep less than 7 hours, your brain does perceive it as stress. And when stress hormones are high, like cortisol, prolactin, right, they do interfere with fertility hormones. And all of this is easier said than done, but we do say, any little adjustments you could make, it'll really help, right? Medications, minoxidil, finasteride, SSRIs, they all affect either ejaculation, libido, erection, right? So really important to screen for those. And ethnicities, last but not least, I wanted to stop here. So consanguinity, very important, right? So especially in people with recurrent pregnancy losses. So really important to screen for, is there any relationship? Because there is a high risk of autosomal recessive abnormalities and so chromosomal abnormalities basically, and recurrent pregnancy losses, especially if they appear early in pregnancy, first trimester, right? And so, certain ethnicities are predisposed, like with certain ethnic backgrounds, the predisposition to, for example, cystic fibrosis, right? And we would expect, we would have higher suspicion for absence of vas deferens, right? And so for female, some of the history, so gynecologic history, right? So we in detail menstrual. So when was the time of your first period? History of, fibroids, polyps. The way I ask, and again, just to rule out each cast, I check tubal factors, right? And then uterine factors, and then ovarian factors. It just kind of systematically goes through everything. Contraception, was there any IUD use? Were there any OCP use? For how long? Any complications, right? When were they removed? Pap smear, intercourse, very important. And I'm happy somebody said that, but you'd be surprised, right? So, some partners don't even live in the same country, and they will say we tried for a year, right? And so that's not trying for a year. Optimal frequency of intercourse is during that week of ovulation, if we know that that's the week of ovulation, of course. And sometimes, the people will say, well, I use those strips where they buy, and they're wonderful in people with a regular 28-day cycle, right? But they are not accurate in people who have cycle every 45 to 60 days or so. And so during that week, the optimal frequency of intercourse is every other day, right? And some people say, well, what about every day? What about every 3 days? Again, if you do it every day, it will not increase your chance on pregnancy. It just better for sperm to accumulate and then have it every other day. And asking about lubricant use, right? If they're using lubricant, it must say fertility friendly, because a lot of them do interfere. That's the purpose of lubricant as well, because they do interfere with the sperm motility as well, all right? Obstetric history, so pregnancies, mode of delivery. Was it C-section? Was it vaginal delivery? Any complications during pregnancy? Any complications during delivery? Was there any issues conceiving with those pregnancies, right? And any treatments tried as well. Surgical medical history is always, of course, important. Social history, equally important. Ethnic backgrounds, caffeine intake. So there is actually evidence that suggests that if one takes 2 caffeinated drinks per day, 2 or more, the chance of getting pregnant is lower. And if they do 5 or more, the risk of recurrent pregnancy loss is higher. When I say 1 caffeinated drink, that is equivalent to 100 milligrams of caffeine. And so, some coffees have less, some more. So that's another thing that really contributes as well. Diet, family history, yes, height and weight, and we do calculate BMI, and I'll stop a little bit later on this. So back to our case. For the purpose of this lecture, I had to rule out a male factor just because, there's not enough time. But Sheila tells you that she has been struggling with irregular cycles every 45 to 60 days. She also tells you that she had a laser hair removal on her chin and neck due to excessive hair. And then she used Accutane as a teen for her acne. And then you take your weight and height, and then the BMI is above 30. And so you follow Sheila with the serial bloods, as I mentioned, right? Like all those days we kind of do blood work and ultrasound, and those are, you appreciate those little follicles. And blood work did not show increased androgens, right? DHEA and some of the androgens. Ultrasound showed PCO appearance of both ovaries. And what is PCO appearance? Basically, each ovary is supposed to have over 12 plus follicles on each side, okay? And so diagnosis of PCOS, fairly straightforward, but a lot of family doctors are confused with this possible PCOS. We will get the referral. So Rotterdam criteria is most commonly used. There is some other criteria, but most commonly used and fairly straightforward. I love it. It's very straightforward. So there is 3 criteria, right? So oligo or anovulation. So there is no ovulation happens, or it happens infrequently, right? So if somebody ovulates 12 times a year, there's much higher chance of getting pregnant, compared to somebody who ovulates once or twice a year, right? And so hyperandrogenism, and this could be biochemically found in the blood, right? That the high male hormones, or clinically patient reports to you, I have acne, I have hirsutism, like I'm suffering from this. And so the third one is polycystic ovaries on ultrasound. And if you remember with Sheila, she really did meet all 3 of them. So she, her let me see what's next slide. Yeah. So this is just a picture to represent, and this is a classic representation of PCO patients. This is phenotype A. Now, I do want you to know there is 4 phenotypes. The milder version is phenotype C, and they do not necessarily look like PCO patients. We call them phen PCO patient, if you will. And so the approach is a little bit different, and the treatments are a little bit different. And again, I don't have enough time to kind of get into it, but a lot of times this is going to be your, classic PCOS patient. Maybe I'll stop age. So hyperandrogenism, you can see the male hair pattern, right, as well as acne, abdominal obesity, and you see acanthosis nigricans or nigricans. This basically shows insulin resistance, right? So a little bit about, well, actually, I want to stop a little bit. How do I explain to patients, right, what PCOS is? So what happens in PCOS patient is that their pancreas produces normal amount of insulin, right? But peripheral tissue, let's say muscle, because it's the largest peripheral tissue, really, does not senses it. So there is insulin resistance, basically, right? Not diabetes, but insulin resistance. And so then there is a constant negative feedback to pancreas, hey, produce more insulin. And so pancreas is in a constant overdrive of production of insulin, tissue doesn't sense it, and there is this ongoing loop, right? And so when we have high insulin production via indirect pathways, there is a high androgen productions. And we have high androgen, there is no ovulation happening, right? So that's why I explain it this way to patients, the lifestyle, very important. And we typically really start off maybe 8 weeks of lifestyle changes only, because a lot of them will get pregnant with this little changes, because reduction of body weight by 7% makes people ovulate, right? With PCO patients, because they have insulin resistance, it's easier said than done. They have hard time losing weight. They will say, like, I don't eat, basically, but I have hard time losing weight. And so what I usually tell them, this is a lifelong condition. It's not something like you are going to wake up and not have it tomorrow. So you have to come up with something sustainable. Do not eliminate completely all your carbs or fat, but certainly you must have lower carbs and lower fat. And the reason I explain it to them is because women with PCOS are at a higher chance of certain conditions compared to women, general population. So conditions such as high blood pressure, all the metabolic conditions, right? High blood pressure, diabetes, dyslipidemia, obesity, infertility, anxiety, depression, even endometrial cancer, right? Because they're exposed to unopposed estrogen a lot of times. And so I tell them that it doesn't mean that you're going to have it, but to avoid that, you really need to work on your lifestyle. And we suggest low carb, low fat diet. And I can't stress enough how much I tell them, do not, do 1,200 calories a day, because it's not sustainable. You're going to start hating it in 1 week, and you're going to drop it. So low carb, reduce a little bit of white pastas or white breads or white rice, still have it, but reduce the portion. Same with low fat. And then physical activity. What I usually say, anything that's good for general health is really good for reproductive health, right? So same 150 minutes applies. Well, patients will say, well, I walk every day, and walk is wonderful. As long as you're getting some steps in, I'm all for it. Better something than nothing, right? But if you don't increase your heart rate, the stroll doesn't count. Like, you do have to moderate exercise. And I tell them, I don't need you to lift, I don't need you to run, but definitely maybe speed walk, go for a hike where there is up and downs, right? Like something to exert yourself a little bit. Yeah, that's pretty much all I wanted to say for lifestyle. Now, supplements, they do work in PCOS, and this is actually evidence-based. And CoQ10, I will say briefly, it's a very good antioxidant, right? So at times it improves sperm quality and egg quality, but more importantly, because it's cofactor in one of the mitochondrial functioning, it's good for energy production. So it's a wonderful supplement for patients to take. Inositol, it is a supplement. We typically recommend 2 grams twice a day, so 4 grams of a total daily dose. And it actually does work. A lot of people with lifestyle changes and inositol will ovulate within a couple months. And what it is it's an insulin sensitizer. And so it really works, and it's evidence-based. It's not just a supplement that we recommend. Now, prenatal vitamins, briefly stop here. There is two types, 1 and 5 milligrams. Most patients are on 1, but it is important. It's over the counter, so it's easy to tell patients, just go to pharmacy, tell them I need pregnancy vitamins, right? And so all prenatal vitamins have about 1 milligram of folic acid. People with BMI over 30, diabetes, any family history, any risk factors require prescription 5 milligrams, or they can take 5 of the other ones, which is inconvenient, but still. And so vitamin D, vitamin C, omega-3, melatonin. Melatonin we don't use for sleep. We just use it as an antioxidant. So that's something to note as well. But it does improve sleep, which works for us well as well. Vitamin D, we do it routinely. We started recently do it routinely because it's extremely common. The prevalence is probably every other one of my patients have vitamin D deficiency. And depends on the deficiency. Like if it's in 32, 45, even 60, low vitamin Ds are associated with a low pregnancy rates and high miscarriage rate. And if we pick this up soon, it's just easy thing to fix. And it's not covered under OHIP, unfortunately, but I do tell them, you don't have to do it, but it's an easy thing to fix if we pick it up early. Pharmacotherapy, interesting step. So metformin. So people get scared when I tell them that, well, Dr. Williams and I want to put you on metformin. And so do I have diabetes? No, you don't have diabetes. The only reason metformin is a wonderful, wonderful insulin sensitizer, right? And this works more for type A PCO patients. It works magic for them. So 1 in 4 will ovulate, so 25% of them. And so what happens, right? So now when the pancreas produces insulin, the peripheral tissue is able to sense it. And so there is no constant overproduction of insulin. And so then male hormone drops. And so they start ovulating, right? So works magic for like typical PCO patients, especially if they do comply with your lifestyle and they sleep better and they take all the other supplements. It really works well. We do tell them ideal effective dose for those patients is typically 500 milligrams TID. Because a lot of people on metformin will develop GI side effects, right? We do say that always take it with the food. And I typically tell them first week, take it once a day, second week, take it twice a day, and then third week, work your way to the effective dose. Clomiphene citrate, I think it's available from like 1960s, and it's off-label use, but this also works quite well. So it's a selective estrogen receptor modulator. And so the way it works, it tricks your brain thinking that there is no estrogen, right? And so what happens, there is a negative feedback to your pituitary gland, and then pituitary starts to produce FSH and LH. And so FSH tells the ovaries and follicles, hey, grow, develop, right? So it stimulates. And it does have 4 to 9%, I believe, risk factor for twins. And I think maybe 1 to 2% of triplets as well, which is higher than general population would have. But it works very well. Of course, it comes with side effects, and so, but it really works well with people who do not ovulate. Letrozole, another very effective medication, a little bit less risk for twin pregnancy. I think it's up 2 to 4% of twin pregnancy in letrozole case. And it's aromatase inhibitor, right? And so there is no conversion androgens to estrogen, and so less estrogen, again, negative feedback, and then more FSH and LH is produced. Now, those were all oral agents, and they're extremely inexpensive. I mean, they have milder side effects. If we usually say, try this for 2 to 3 cycles. If this doesn't work, then we go to injectable ones. And so injectables are more expensive, more side effects like hot flashes, vaginal dryness, mood changes, headaches, right? And so this could be either combination of LH, FSH, right? Gonalaf or many other ones, or gonadotropin releasing hormone itself, right? And so the risk of ovarian hyperstimulation syndrome, we tightly monitor women for this one because so what happens because of high estrogen, vascular permeability increases, and so third spacing happens, right? And so fluid accumulates in peritoneum or mediastinum where it's not supposed to be, and it's a dangerous condition to have, but we monitor them quite closely. And so HCG, this is also medication. fairly inexpensive. I have to talk about prices because infertility, it really adds up, right? Because none of this is really covered unless you have a very good benefits. And so HCG, what it does, it simulates LH surge. So I will talk about it in combination with intervention. And so this is kind of fun part that I personally really enjoy, especially IUI, like I love doing it. So timed intercourse. So what happens is, right, if in 4 weeks, and 4 weeks is for younger patients, right? If we have 4 weeks to wait, basically. So if in 4 weeks, if they use metformin, they were compliant, nothing happened. So what we suggest is either moving to ovulation stimulation agents, right? So either oral or injectable, depending on a specific case. How fast do they want? What are the financial situations and so forth? And what are they comfortable with, of course? And so timed intercourse, what we do is, so now when we know their cycle, right, we still bring them on day 3. We check their estrogen progesterone. As long as they're within normal limits where they're not high, we start stimulating them basically, right? And so we follow them again. They typically take this medication for about 5 days, day 3 to day 7. On day 8, we bring them back and we check. Do we have a good response, the response that we wanted to have? Like, are the follicles growing? Are they developing? And so once we see, we call mature follicle anything 1.6 and above. Ideally, it will be like 1.8, even 2.2, right? That would be wonderful if we get there. And also in combination, it's either the size of the follicle or LH surge, right? And so if we see either is happening, what we do is we do HCG, which is a trigger shot, which allows follicle to be released. And we tell them when to have intercourse. And it's very similar to IUI. Some people are not comfortable with timed intercourse. Some people, feel like this is more effective, which very little bit it is. It also depends on the case. But what IUI is so we basically monitor the lady, and whenever there is an optimal time for a follicle, we trigger. So we make the ovum to release the follicle that we need. And the same morning, the partner comes in, deposits the sperm, and we do a sperm wash where we basically pick the best swimmers, if you will. And it's in a syringe, and with a thin catheter, we again through vagina, through cervix, we really deposit the best swimmers into the fundus of the uterus, where sperm really has to do very little work to go and fertilize the egg that is very ready to be fertilized. And so by that time, we know that, tubes are open, the cavity is good, and we usually put them on progesterone because it just creates a favorable environment for implantation of the baby. So laparoscopic ovarian drilling, this is a little bit invasive, but what usually happens is, this is for thin PCOS more so, because they will likely not respond to metformin because insulin resistance is not the main issue with thin PCOS patients. And so I shouldn't say thin PCOS, we do call them, but it's phenotype C, I should say. What we do with ovarian drilling is we do drill 3 to 10 little holes 2 millimeters into the ovaries where theca cells are supposed to be. And theca cells are the ones that produce androgens, right? So this way we diminish androgen production, and ovulation rate is quite amazing. It's 75 to 85%, and a lot of them will get pregnant within 3 months after this procedure. If they didn't get pregnant within 3 months, unlikely that this procedure is going to work for them long term. So back to Sheila. Before her scheduled 11-week follow-up appointment, she informed you that she has been adherent to metformin and her supplements. She is happy to inform you that last 2 months she's gotten her period fairly regularly. She was able to change her lifestyle with low, not carb, but carb diet, and lost 3 kilos. And the ultrasound that was done, this is not exactly her ultrasound, but this is how it would look like. We appreciate yolk sac, we appreciate yolk sac and gestational sac, which is wonderful news for a patient. And this was all for my presentation. This is my team. We just recently did the 6K walk. I'm very passionate about this field. I love it. I talked to you about PCOS because it's one of the common causes of infertility. It's one of the easier ones to understand and not to be confused. But I think more, if one thing we can take away is really understanding that time is money in this situation. Like, we got to act fast, right? So start the conversation throughout that question. What are your thoughts about family in the future? And it opens the dialogue. If they shut you down, that's okay. If not, refer them to fertility specialists, or even start your investigations yourself, right? Like, it's as easy to order a sonohysterogram, day 3 bloods, AMH to see ovarian reserve and certain things. And don't forget the partner, right? Semen analysis and all. And this guy in the green shirt is my son, who always supports me, and he's here today with me. But yeah, thank you very much all for coming. I hope this was informative. I hope it wasn't rushed. Any questions that you guys have? Thank you. Did I finish early, or? Yeah, I think so. I'm here again. I'm here again for alcohol. Oh, sorry. Yeah, some of you I'm going to see in alcohol use disorder. Yes, go ahead. Do we also? We do IVF. Yes. Prior to retrieval, medicating like either performance versus patient, or run for an patient prior to and then we do retrieval and transfer, or yeah, so it's a very complicated question because it really depends on the cause of IVF, right? There is numerous protocols that we use. There is a long antagonist protocols where we use Lupron, right? Where we suppress everything for some time. And then metformin wise, if there is a PCOS, we absolutely use it irrelevant of, if there is retrieval, no retrieval, IVF, no IVF, we absolutely use it because it improves insulin sensitivity. And not only it improves pregnancy rate with IVF as well, but it also reduces, because PCOS patients have complications for pregnancy, right? Like increased risk of gestational diabetes, and that affects like macrosomia and some other things that comes with it. And so we definitely do treat it. If metformin was started solely for purpose of treating PCOS, we do taper it by 14 weeks. So we typically will say, by 12, you drop it to BID, and then, 13 weeks daily, and then you stop at 14 weeks. So we taper metformin once we get what we want. But yeah, we do treat with metformin. And with Lupron, again, it depends on protocol. We have short protocols, we have long protocols. It really depends on the etiology of why we are doing it. Time, sometimes even working out time during, holidays, if we need to do, like we could use Gonalev, we could use simply, like a lot of things could be used, depends. I don't know if that answered your question. Yes. Thank you. Reason it fails. Sorry, did you ask effectiveness of IUI? I think it depends on the age of the female, depends on ovarian reserve, because again, if the age is more than 35, egg, we might have a good AMH, but the quality of the egg is not good. And we have people in their 40 trying, and we're pretty straightforward saying that, it's very unlikely that will happen. But effectiveness of IUI, women, let's say 35 to 40, I'll say 15% chance of pregnancy per cycle. Typically, we again will do 3 cycles. I don't have a good answer for you. The reason it could fail, I guess it would be the same reason. I don't know why it wouldn't fertilize, but you're right. Like theoretically, it shouldn't, right? Especially if you give 3 cycles, and a lot of them will conceive in 3 cycles. But I really don't have a good answer for you. because you're right, there is an optimal egg, optimal sperm. And having said that, we do pick the best swimmers, but there's a difference, right? Like sometimes we have 4 million sperm, which is a still good number, but it's not as good as 10 million sperm, right? That could contribute. Anxiety contributes, a lot of things contributes, but I don't know I can answer that question, or I don't know anybody could answer that question why it fails. It's similarly to IVF, right? Like we don't know, it just implantation doesn't happen and we don't have a good answer. We just try our best to optimize everything, and then if it fails, it's just hard to tell. Yes. We do. In fact, if there is any suspicion, typically I do endometrial biopsies before that happens if we have any kind of concerns, because endometritis is not uncommon, and it could be simply because of PCOS, or it could be because of infection, right? And so we do to rule that out. If we find something, we treat them with Zithromax or whatever the cause was, and then we do the either transfer, or because before we do transfer, we make sure that everything is clear, right? Because it's a lot of money, it's a lot of side effects, it's a lot of hustle. It takes months to get the woman there, right? And they go through, it's unbelievable. Sometimes it breaks the families, right? It's that stressful, and it's hard to believe, but I will tell you that, and I'll go back to your question, there is evidence that shows that couples that cannot conceive go through the same stages of grief as one was diagnosed with terminal diagnosis like a cancer. And the reason being is because, it's a natural process, right? That people don't require an effort. Some people just get pregnant and then they are deprived of it. So they really grieve, it really affects couple. So it comes with a lot of emotional, thing with it. Back to your question. Sorry, what was the question again? Yes. So ERA test, there is no good evidence. Yeah, so they're saying there is no good evidence to do it. So we have done it, but there is no good evidence to support that it actually improves the outcome. So we stopped doing it because I think it's $500 to $700, and then you can't justify to a patient that, well, it was good, but it still failed, right? What we do is we do endometrial lining check, and so if it's more than 0.7 centimeters, then we know the endometrium is ready for a transfer. So we only transfer it if it's 0.7. If it's 0.6, we will not transfer. So we don't do ERA per se, because again, it came and it was all exciting and people were doing it, but there is no good evidence to say that, some clinics still do it. Yes. So anxiety and stress. So we don't necessarily kind of go in depth. We definitely do suggest that if it's at the level that, like, we have, in fact, I think she has some kind of conversion disorder, like such as stress, right? So I did suggest to go back to a family doctor and talk about SSRIs, and family doctor refused to put her on SSRIs because basically he was uncomfortable because she's trying to conceive. So I will write a letter. I'll say, maybe not Prozac, but citalopram, sertraline, they're safe in pregnancy. There is no evidence that is associated with birth defects or anything, or any negative outcomes. So I could write a letter and suggest, stress-wise, I do suggest myself walks, mindfulness, breathing exercises, right? And I actually stress that, saying that, you have to pick yourself up, because not that anxiety doesn't help, but it harms. Like, you're putting all this effort, and if you're constantly anxious, like, your body just simply won't carry out the pregnancy. And so I try to provide counseling myself as much as I have. If they need more, We have a counselor. Typically, it's more so for like IVF patients because it's a whole different scope, if you will. But I guess whatever I can do. And then another thing is, family doctor, I could give recommendations if they're worried about if it's actually anxiety disorder, right? But I think, again, doing what you love, breathing exercises, yoga, relaxation, mindfulness, all that kind of stuff. That's as much as I do.
Better BRIA, is through the reproductive cycle for reproductive mental health support. So they have infertility support, they have counselors, they have psychiatrists, I think they're even like developing support groups. And infertility support groups can be very helpful. It's such a regulating process, and you know that you're not alone, but also that some medical things are much better, and then you have to share experience. So Resolve, the website in the US.
Yeah, there is an app. Thank you, actually. That's another thing. Thank you. There is an app here as well. And then the other thing that I do recommend also is searching on Google the groups. It actually helps great deal because you can relate to people. They tell you their experiences. That's another thing. And there are some apps and yeah, so I guess there are resources. I don't know if we necessarily do as much as we can, but we really try our best. Yes. Sounds good. I'm happy it provoked the discussion.
Just build on that, that's the stress level, what patients hold, the financial stress put on them based on which clinic they choose. The different clinics have different prices for, and they'll have specials and that kind of thing. So privatized healthcare essentially, right? So that shopping around for IVF and that kind of thing can add to the stress of you're already really stressful.
It is.
On how the clinics sort of base their pricing or anything like that.
I actually wasn't sure that there is differences in pricing because every woman in Ontario who has a health card and below age 45 is a one-time life opportunity, not opportunity, but coverage from OHIP for IVF cycle. If you have medication coverage, good coverage, then medication is the thing that adds up, right? Because they're expensive. The injectable are expensive, at anywhere from $2,000 to $5,000 could add up. And so, but IVF cycle could be $20,000, $25,000, and I think it's somewhat the same across. No, I really don't know the pricing. I know our clinic. Again, I'm fairly new in the field. Like it's been a year and a half. I'm still learning, and I presented PCOS today because I kind of feel an expert already because that's the cases that I take. I do new assessments. I do like procedures, a lot of procedures, and some of the PCOS follow-ups more so. And so I don't know a lot about pricing. It is, and it varies from clinic to clinic. In our clinic, it's anywhere from 1 to 2 years. Now, we do try to accommodate females who are, late 30s, 40, but unfortunately there is, and yeah, and yeah, absolutely. Thank you guys very much, all.